each of one of us, that means myself, Olivier, and Adrian, should give an account of our experience about this topic of long gap esophageal atresia. And I think we have to stick to this. My idea was to try to show you how we have created our own attitudes and our own strategies for the treatment of long gap esophageal atresia. And I think I should start by recalling something that it's important. When we want to know whether a COVID vaccination is good or not, we take 30,000 individuals that are supposed to be prone to being infected by the disease, and 30,000 others. We divide them into a group with vaccination, another group without vaccination, and after some months of observation, we decide which is the best strategy. But when dealing with esophageal atresia, particularly with the long gap one, you have to take into account that we are dealing with a very rare disease. You know that 1 out of most 4,000 births, and if you take the long gaps, that means 10% of these are type 1 or type A, and perhaps 10 or 15% more are long gaps that are not amenable to primary anastomosis. We are dealing with a very small number of patients. And if you reduce that to the scope of any national or institutional population, you will realize that it's very difficult to have attitudes that are based on solid grounds. And obviously, in this case, you are very influenced by your personal experience, by your observational experience, and also by the trends. This is like you know, when dealing with the length of the skirts or something like that, that change every year, and people are very influenced by that, and you have to take into account these things. So the good thing today is that we are going to have the opinions of people that have a large experience of the treatment of esophageal atresia, and particularly because we have this experience extended a very long period of time. And so we have witnessed different attitudes, and we have had time to tailor our attitudes based on our observation and our personal experience. And that's what I'm going to try to transmit you with the telling you how I personally tailored my attitudes about that. I started my surgical career in 1968. I was in Paris with Professor Pellerin, was enfant malade. And at that time in this institution, we had about 20 esophageal atresia cases every year. Mortality was at that time not less than 25 or 30%. We had no intensive care units, no endoscopic things, and obviously long gaps and type 1 cases constituted about 10% or 20% in whole of the entire experience. And at that time, what we did was to accept that leaving the upper pouch to grow was good for some cases, and we could perform the anastomosis after some months. But that involved things that are difficult to think of now. That involved sometimes hospital stays of 5 or 6 months, and of course many deaths in the meantime, because these patients were not always able to cope with this.
Venuto nel servizio di segreteria telefonica del numero 3288829.
Can I go on? Can I go on? Can you hear me?
Yes, so I'd try and go on.
All right, no problem. Well, so I stayed there for some years, and at that time we had, I told you, about 20 cases every year. And by not personal at that time, but observational experience, I understood that you could eventually put together both ends of the esophagus, even when there were long gap or type 1 cases. Then I moved to Madrid in 1971 and to my current institution. And at that time, we have even more. We have 25 cases a year. And we had already an intensive care, neonatal intensive care unit. Endoscopic goodies were not totally developed at the time for pediatric surgeons. And the attitude at that time was performing lengthening of the both ends by the Howard and Myers procedures of introducing dilators from the gastrostomy and on the upper pouch. And after some time, we could eventually achieve anastomosis without tension by this procedure. But that left also some patients that died in the meantime, because this is not always as sexual, as you know very well. And then in 1976, I moved to San Sebastian, a small city. I had experience that is similar to the one you have in many of your institutions now. That's a place where we had a referral area of about 1 million people. That means that we had 3 or maximum 4 cases of esophageal atresia every year. So our experience, personal or observational, during the 15 years I stayed there with long gaps was very limited. And I can tell you that at that time, I was convinced that some of the long gaps could be anastomosed primarily and the other ones could not. And I had some cases of replacement at that time. And then in 1992, I came to Madrid, my original institution. Things had changed a lot. The birth rate diminished very much. There were many other services around in Madrid and elsewhere. And we had about 10 or 12 cases every year of esophageal atresia. So a limited number of them with long gaps and with type 1s. And ever since, I have been developing my attitudes based on the observation, my personal experience, and 2 other things that I'm going to mention briefly. First, for many years already, I had been developing functional studies of the esophagus when I was in San Sebastian and also in Madrid. And I have been very concerned about the quality of the esophagus we got in patients with esophageal atresia, long gap or other. And secondly, we developed in Madrid experimental studies that enable us to reproduce the malformation and reproduce also some of the functional deficits that are observed in human beings with esophageal atresia. So we could see that, first of all, the structure of the esophagus, even in the non-long gap cases, is never normal, and that's easy to understand. Secondly, any traction procedure further hinders the quality of the esophagus because you shorten it, because you change the anatomy of the gastroesophageal junction area where all the anti-reflux mechanisms are set. And also we could demonstrate that the innervation, extrinsic innervation, the vagus nerves, the laryngeal nerves are not normal in esophageal atresia cases, in any case, particularly long gap cases. And also that the intrinsic innervation, the neurons that are embedded in the wall of the esophagus are not normal. So we can't expect normal motility, normal function of the esophagus in esophageal atresia. And also that when you had to lengthen the esophagus, the results are even worse. And this was more and more evident to us because our particular interest in esophagus function made of our center a referral center for esophageal problems. And we had a lot of patients coming in from different places with complications of all sorts of procedures, including lengthening procedures and replacements and so on. So with all this background, I developed my current attitude. I am not operating anymore patients with esophageal atresia, long gap or not, but I decided already, let's say 15 years ago or more, that the best issue was to perform, when you cannot perform an anastomosis, a primary anastomosis, the best way of doing that in my hands was to perform a left side esophagostomy and a replacement in the intramediastinal route, either with the stomach or with colon. And to illustrate that, I'm going to show you just 5 slides, if you let me show you that, if I can. Yeah. Okay, so I have selected a few slides from relevant authors who have been concerned with this problem. One of these is this series from Dublin. You know, Prem Puri has always supported the idea of delayed grammar anastomosis, and I summarize his experience in this slide that comes from a very relatively recent study, 2007. And you can see that out of 27 patients collected along this long period of time, 2 had replacements for different reasons, and 3 died in the meantime, and 22 were included in the study. And you see that the follow-up was relatively long. During this period, 4 more died. And if you take together 3 and 4, you have a huge proportion of all these patients that died during this procedure. And you see that of the 22 included, you had 94% stenosis, 1/3 of which were resected, and 88% had reflux, 2/3 required Nissen, and 1 out of 5 had Barrett esophagus. So, in my opinion, that shows that the quality of the procedure was functionally not perfect, far from that. Probably Prem himself and Florian Friedmacher were also concerned with that, and they performed later on in 2012 a meta-analysis of the complications of the long gap, the treatment of long gap esophageal atresia. And I just highlighted some of this data here. Out of 44 studies with 451 subjects, you see that the proportion of stricture is more than half, almost 2/3, that the symptomatic reflux, and this is something that I can contend because that means nothing. I mean, 47.8%, you don't know exactly what that means for symptomatic gastroesophageal reflux. That more than 1/3 had esophagitis, and again, I have to say, I don't know very well the criteria, how did they diagnose the esophagitis, and you see that the Barrett metaplasia was again in roughly 1 out of 6 patients. So functionally, again, and this includes not only the type A, but also the long gap esophageal atresia patients, the functional results were not perfect. And then I go into the Fokker growth procedure. I have discussed that many times with Jake Fokker, because he have never presented, in fact, all his data about all the patients and what happened with all the patients. When I discussed that with him for the first time, that was a procedure with a first operation to set up the traction sutures, 1 thoracotomy, then a second thoracotomy for the anastomosis, if there were nothing inside. And then you see that when he presented in his paper in seminars, his first 60 patients that took about these 12 years that you can see here, 42 were followed more than 3 years. And you see that all required dilatations for stenosis. You see that all required Nissen procedure, and all 1/4 to 1/3 of all cases required a second Nissen, showing that the reflux was definitely a problem. But as I told you, I don't think that Jake Fokker presented all his data, but I just went into a presentation that his group did, and he was present, I remember that, at the International Symposium of Pediatric Surgical Research in Leipzig in 2008, with the same figures that were presented in part in the seminars article. And you see that out of these 42 patients followed up for more than 3 years, 7 were lost and 3 were dead. So that means that that's 25% of the cohort. And out of the 32 studied, you see that, again, dilatations 100% of dilatations for stenosis, 81% of resected stenosis in these cases, and 93% of Nissen. So then we come again to this thing that was at that time a first operation if nothing happened, a second operation for the anastomosis, a third operation, third thoracotomy for resecting the stenosis, a fourth operation for Nissen. And you know, it's difficult to accept that this is a functionally satisfactory procedure. I don't contend, and other people may support this issue, but in my opinion, this, and according to the complications I have seen from failed Fokkers in my institution, from elsewhere treated in my institution, I didn't accept that as a very valuable situation. And finally, this is the last picture that I want to show you. This is a relatively recent article from several institutions in France, including Lille, which is, as you know, one of the referral centers for esophageal problems in France, and also Strasbourg experience from François Becmer. This was published in the Annals of Surgery and was quite, you know, strict in the diagnosis of the Barrett esophagus. And you see that out of 120 patients more than 18 years, 51 had Barrett esophagus. That's 40% roughly. And you see, and this is what I want to show you, is if you took the type 1 and type 3 cases, you see that Barrett esophagus was very predominant in case 2 cases, and less predominant. Those people who had no Barrett esophagus were less predominant in the Barrett esophagus, non-Barrett esophagus group. The odd ratio for this risk was almost 5 times. So that means that having a type 1 and probably a long gap case means that you have 5 more times a risk of having a Barrett esophagus than if you don't have that. So I end up with this. The only thing I wanted to show you is that it's not a question of religions. We have our attitudes tailored according to our experience, as I have told you. And all religions are respectable. I don't pretend that what we propose as the best treatment is the best treatment. We respect all other treatments, but you must be aware of the limitations of the way you tailor your attitudes, because it's impossible to have enough experience in this particular form of the disease to be based on solid grounds. And you have to accept that all other attitudes may be good, the yours is perhaps the best, and you have to respect all the others. Thank you very much, and I will stop sharing the screen.
Okay, thank you very much, Juan, for your very nice presentation and also for your experience. It's a very long experience, and thank you for your final consideration. Now, Steve Rothenberg, the thoracoscopic treatment of long gape esophageal atresia. Please, Stephen, thank you very much.
Well, thank you. Thank you for including me in this group. It's a great honor, and it's great to see all of you. And I feel a little bit humbled, you know, doing this. I certainly don't have the largest experience in the world with esophageal atresia, but we do, as most of you know, since 2000, we've been doing all of our esophageal atresias thoracoscopically. And I'm going to focus primarily or totally on long gap. And let me go ahead and share my screen. And let's go to the.
Yes, we see your laptop.
Slide. Okay, good. Okay, you see that?
Yes, perfect,
okay.
perfect.
All right. So, I mean, obviously, everybody in this group knows the gross classification, but I do think it's important to note that when we talk about long gap now, we're really only talking about types A and B. And I personally have never seen a type D, so I suppose that could be as well. But type Cs are not long gaps by definition. That's now the international group on esophageal atresia. And I would just, I would support and emphasize Juan's comments about the Fokker procedure. And I think it's important to note the majority of his cases are type C. And I too have experienced having to take care of a number of patients who've had Fokker procedures who've had significant complications. And that's not to say that my patients don't have issues and strictures and complications, but it's to say that much as it's been presented, the Fokker procedure is not a panacea for this operation. And I think many of the patients that they did, we would have gotten one operation in the hands of many of the people in this group. So I think you just need to look at that with open eyes. And I realize that the treatment of esophageal atresia has become much like religion, and it's hard to not do that because we all have our personal biases in what we believe and how we do. I'll just say that, you know, my preferred operation, because I'm not really going to talk about it, if we can't achieve an anastomosis, and that's actually only happened once to me in the last 20 years for an atresia, is to do a gastric pull-up. So that's what we do, you know, much the way that Arnie Koren has described, and that's our preferred operation. Having said that, I've done one gastric pull-up for a long gap esophageal atresia in the last 20 years, and we do perform that laparoscopic and thoracoscopic assisted. So this is basically our management protocol for patients who have type A and B esophageal atresia. So, and I'll talk a little bit, and some people are, including Darius, are trying to change this algorithm and seem to be having good results. But for us, still, you know, the first step on is when we have a baby with pure atresia, we place a G-tube on the first day or two of life, basically to be able to initiate feeds, and then also to determine the gap. And then in general, I have let them grow for 3 to 8 weeks with bolus feeds, trying to accomplish a couple things. One, just get the baby bigger and stronger. Two, to, you know, see if by doing bolus feeds we can increase the size of the lower pouch and toughen it up a bit for surgery. And then it also allows us to do our gap study. Now, initially, I was waiting 2 to 3 weeks to do a gap study. We're now doing that earlier, in part because of what Darius and David Vanderzee have accomplished and done. But I think it's you know, we still are not getting it right away. You know, not immediately on the first day or two of life. We're giving a little bit of time for that to heal and then go in. And then I do think it's critical in patients who have a pure atresia or appear to have a pure atresia type A, that you do a bronchoscopy, because I think the incidence of an upper pouch fistula is much higher than is recorded. I think, in fact, it may be as high as 20%. And I think, you know, we're certainly seeing a much higher incidence of that, and I'll show you in our numbers. So I don't, you know, I think it's debatable whether you truly need to bronchoscope a patient with a type C. As I said, I've never seen a patient with both an upper and lower pouch fistula. And I think for a training exercise, it's good to bronch them. But honestly, when we put those babies to sleep, what my goal is to do for the anesthetist is to get control of that fistula as soon as possible, especially because I'm doing the procedure thoracoscopically and I'm compromising them a little bit by, you know, CO2 insufflation. So honestly, I don't bronch those patients because I know I'll find where the fistula is. It doesn't change what I'm going to do. And I've never seen both an upper and lower pouch fistula. So I'm not really worried about missing that. But I think a lot of people believe it's the appropriate thing to do, and I think that's fine, but I don't. But I always do a bronchoscopy on a patient who I think has a pure atresia. And these are our numbers since March of 2000. And you know, that March was actually in the spring of 1999 is when Tom Loeb and I did the first thoracoscopic esophageal atresia in Berlin in front of a live audience on a patient that Dr. Waldschmidt had, who was about 2 months old, I think, 6 to 8 weeks old, who they had been taking to the operating room every other day to put down metal bougies to dilate both the upper and lower pouch. They'd put in a G-tube, they'd done a gap study, and by the time we came, it certainly was not a long gap. It was the two ends, actually had an x-ray of the two ends with metal bougies in them, and they were overlapping. But you know, it was the first purely thoracoscopic procedure ever done. And then in March of, and I think it was April of 2000 is when I did the first type C thoracoscopically, and I presented that video at IPEG. So this is, you know, since that time, I've done 155 type Cs, but we're going to focus on the type A and B, which are, I've done 20 type A's and 5 type B's. So you can see that the incidence of an upper pouch fistula in my personal experience is in fact 20%, which is much higher than I think the books quote. The approach, again, is thoracoscopic. We don't use single lung ventilation. We just use CO2 to collapse the lung. We're working in the posterior mediastinum, and so the patients have to be in a bit of a modified prone position. So basically, we position them with the left side down and the right side up about 45 degrees, so that when we collapse the lung, it falls out of the way. Initially, we tried to use lung retractors and things like that, but we don't do that anymore. We just let CO2 do it for us. But it's important that your anesthesiologists work with you, because if they overventilate the baby, and sometimes we'll have to go up to a pressure of 6 or even 8 initially to get the lung collapsed, and then we back off. But if they overventilate the baby, then you'll never be able to see it. So they need to tolerate a little bit higher CO2s and do that. If we do this in older patients, sometimes patients are referred to me quite late. You know, I've had ones that were referred at 5 or 6 months of age after, you know, being managed conservatively somewhere else. We sometimes will try to get a left mainstem intubation just to give us more space, because those cases tend to be more difficult because the gaps are longer. But in general, we just use CO2. We've done all of these with 3 ports. I use a 4mm 30-degree scope for the procedure. I put that port just behind the tip of the scapula and about the 4th or 5th intercostal space. And then a 3mm port in my left hand and a 5mm port up in the axilla for suture and a stapler if we need it. Now that's for type C. It changes a little bit for the pure atresias, because we don't need a stapler, we don't need clips to divide the fistula. And my ports are oriented a little bit more to working down towards the diaphragm than in a normal type C, just because you have to do more work with the lower pouch. And most of these we've done through the right chest, but I have had 2 patients with a right arch that we've done through the left chest. Sorry. So, you know, the key to this operation thoracoscopically, and the reason I think we have more success thoracoscopically than with an open procedure, is really mobilization of the upper pouch. And for those of you who've done it, you know, you get to see that I mobilize the upper esophageal pouch all the way up into the thoracic inlet. I mean, literally to the back of the tongue. And you can visualize that because you're using an angled scope and looking well up into the apex. And this is impossible to do through an open thoracotomy. And so I think our success has been that I've been able to double and sometimes almost triple the length of the upper pouch. And in fact, in this in this picture right here, you can see, here's the diaphragm. This upper pouch has been mobilized and brought down 2/3 of the way down the chest. So it's really key to getting these things together. I'll then also mobilize the lower pouch all the way down to the diaphragm. I never breach the hiatus because I'm concerned about getting a hiatal hernia, although some of these patients can develop it anywhere. And then if there's an upper pouch fistula, which again, we've seen 5 times, I used to suture ligate it. Now I actually use the 5mm stapler to do the procedure. And then I do a single layer interrupted anastomosis with 4 or 5/0 PDS. I don't leave chest tubes in NGs in cases of type C, but with the long gaps, I always do. I'm assuming there's going to be a stricture. And so one of the reasons I don't leave NGs and type Cs anymore, it's been shown that there's a higher incidence of stricture formation in the type Bs, especially if they're under significant tension. I like to make sure that I have something across the anastomosis, so at least I have control of that. And we do leave chest tubes. So I thought I'd show you a representative video. This was a patient who was born premature, 31 weeks, and was 1.6 kilos, so quite small. We did an NG tube, we put a G tube in, I got a gap study at 14 days, which showed the gap to be 7 vertebral bodies. And then I started bolus tube feeds. And when the baby was 40 weeks gestation, we got another study. The gap was still just over 6 vertebral bodies, but we took him to the OR at this time. So this is basically a full-term baby, a good size one, albeit 4 kilos. And you can see the thoracoscopic setup here. Again, the patient's pushed prone. This baby was scoped, and there you can see the upper pouch fistula. Again, not necessarily suspected. And so the start of the operation is just, I do take the azygous vein just to get it out of the way so I don't stick it with a needle and get it to bleed. But this is really the important part. Here you can see the beautiful ability to see up into the apex of the chest. And in this case, again, we knew we had an upper pouch fistula. I also approach all my H-type fistulas this way now. We just did another one. They're all at the thoracic inlet. It's quite easy to see, but here you can see I'm dissecting up above the level of the fistula and creating that plane between the two. And I think this may have been, it's one of the first cases that we were able to use a stapler on the fistula. So here you can see this fistula comes in right at near the tip of the pouch. And I didn't want to lose any length because we had a fairly long gap. So I divided it with a stapler rather than just cut that lower part of the esophagus off. And this gives a nice 2 layers of staples, and you can see we divided that very clean. But now I can use the tip of the upper pouch rather than have to worry about where the fistula is. But again, I'm dissecting even further up into the thoracic inlet, and you can see the vagus nerve very well. In the last case we did of an H-type, I was even able to see the recurrent laryngeal on the other side. And you're just able to dissect under direct vision very high into the chest. And the device I'm using is the little 3mm vessel sealer that we've developed, which limits any energy spread. So the risk of injury to the nerves and other surrounding structures is quite small. And so I use this technique where I'll just kind of spread, grab tissue, small vessels, seal them, and then tease it off the esophagus. And by doing this, again, you can see that I'm over doubling the length of the upper pouch. And then we go down and find the lower pouch. In this case, the kid had a reasonable lower pouch. Again, I don't breach the hiatus. And I just do extensive mobilization all the way down to the hiatus, but never going across it. And my tendency has been, again, to do these kids somewhere between 3 to 8 weeks of life. I like them to be around 3.5 to 4 kilos. I've done bigger kids, but those are kids who were growing somewhere else, honestly waiting to go to Boston and then got fed up, and then someone heard about me and they came. Those cases are actually harder. And I actually think the gap becomes longer the longer you let the kids grow. And then this is if it's a really long gap and I'm worried that we're not going to get it together in one operation and there's a lot of tension, I've used, previously I've used a knot pusher so that I can see the two ends together, see if it tends to tear apart. I've now switched to the technique that Darius has championed, and I'll show you a short video of his with his kind permission about using an internal kind of slip knot. But I, you know, if I think if the two ends come together, then I'll go ahead and make an enterotomy in either side. Normally I would cut off the tip of the upper pouch, but in these cases, I'm trying to preserve every inch of tissue so that I can get the two ends together, again, expecting that there's going to be stenosis and I'm going to have to do a dilatation. And then I do the anastomosis again with 4050 PDS. The back row is sutures are internal, and then the front row, the knots are external. This is an 8 French NG tube that we're putting past it, and then completing the anastomosis. And you can see that where my fistula, the staple line is just lateral, but we've not had a problem with a leak from that. And so that's how I approach the long gaps. And I've overcome a gap of eight vertebral bodies using this technique. But again, I consider a long gap anything that's a pure atresia over 4 vertebral bodies. If it's less than 4 vertebral bodies, I really don't think it's a long gap. I think we should be able to get them together. The operative times are, you know, not excessive. They're, you know, around 2 hours. 3 of the patients had documented leaks. We've treated all those conservatively, and with time, they've all sealed. Nobody got sick or mediastinitis or problems with that. And in most of the patients, we were able to resume their G-tube feeds within 5 days. 2 of the patients, because of their leaks, we had to wait, I think, to about 10 days. And that's the approach that we've used. And that's, like I said, we've only had one case where we couldn't get them together. It was a case of my partner's, and that child had no upper pouch, and I was not involved with the first surgery. Actually, the patient was a type C, but she'd gone in and ligated the fistula, and we went back, but there was really no upper pouch, and we did some internal traction, but the baby tore those sutures out, and we ended up having to do a gastric pull-up. Now, David Vanderzee was got interested in the Fokker procedure and was a little more believing and charitable, I guess, than I was, and he developed a thoracoscopic variation of that he used with some reasonable results. But then both he and Darius, and you know, since Darius is, oh, these are our results. Sorry, I put that slide in there. So out of the 25 half required dilations, almost, you know, about 40% required fundoplications. 20% of those required a redo fundoplication. But as of now, 23 out of the 25 are on full oral feeds. And we had 2 cases that we did in November and December that are still progressing to full oral feeds, get a portion of their feeds through the G-tube. And this is just to show you, this is an esophagoscopy on one of them. And you can see that they've actually healed their anastomosis quite well. So again, David and Darius have changed the algorithm a little bit, doing internal traction as a newborn. So they're not placing a G-tube, and they're actually operating on the patient within the first 5 days of life. And then they'll bring the ends together under internal traction, and then repeat that operation every few days until they get the ends together. And Darius is obviously on this conference, and I'll let him speak to it more. They don't put in a gastrostomy tube because they don't feel they need it, although they do go in and put in a gastropexy to prevent hiatal hernia. So one thing I don't understand why not to put in a gastrostomy tube, but they feel that, you know, that maybe that prevents the kids from taking by mouth, but they seem to have good results with the kids eating orally and doing quite well. I think they're both very skilled thoracoscopic surgeons. I think these tissues can be quite friable, and the pure atresias we've had lately have all been premature and rather young, and I think it's very easy to tear those tissues if you're not very skilled. So we are now operating earlier based on their experience, but I still like the kids to be about 3.5 kilos. I think if they're much smaller than that, the tissues are small. And this is Darius's video that he kindly sent to me a while ago, but this shows this internal slip knot, and he puts in a couple of them, and you'll see how he then puts clips to support the tissue, the stitches through the tissue, the upper lower pouches, and then he'll tighten those knots and bring the two ends together. And then again, he clips it to keep the stitches from tearing out. Like I said, the last two kids we had were both premature. We operated on them when they were around 3.5 kilos. And we got the two ends together in the first operation, but based on, they were just together. And so based on Darius's experience, we elected not to do the anastomosis at that time. We came back in one case, I think 5 days later. In one case, it was a little bit longer because I was out of town. It was closer to 8 or 9 days. And when we did the repeat operation, I think there was less tension on the two ends, and it made the anastomosis, certainly in one case, significantly easier to do. And so that shows you the two ends being brought together. Now, I would have previously just tried to do an anastomosis there. And then here's the repeat video. This is the video, I think, a few days later, and you can see the stitches are in place, and now there's significantly less tension, and he's able to perform the anastomosis easier. So I think, you know, this seems to be of some benefit in our limited experience with two cases where we've gone back earlier. It did seem to aid in doing the anastomosis. But again, I'm not doing these. I've not had a full-term newborn to try one in. So I'm still waiting a bit to do it. But that's our experience. And I do think that thoracoscopically just enables us to do mobilization that is much, much better than through an open thoracotomy. And these kids, and even if you get a repeat operation, it's done thoracoscopically, and it's not the morbidity of the thoracotomy. So I think it's you know, really makes a difference in this procedure. And so I'm gonna stop sharing my screen. I do apologize. I'm gonna have to leave because I have a surgery that we had to add on last night. And Mario, if it's okay, I'm happy to take any questions before I go.
Thank you very much, Steve, for your fantastic presentation.
Mario, I can't hear you. Maybe I'm doing something.
You listen me?
Oh,
you listen me?
sorry.
Yes?
Yeah, I can hear you now. Good.
Okay, thank you very much for your fantastic presentation. And if it's possible to stay with us 10, 15 minutes, I want to speak Darius for the experience of the technique that you show. If it's impossible, we start immediately the discussion for the thoracoscopic.
Yeah,
me,
unfortunately, I'm going to have to go pretty soon.
Okay. There is a question from the audience, please, for Professor Steve Rothenberg. Please, Piero Bagolan.
Yes. Hi, Steve. Nice to see you.
Piero, how are you?
Just a question. Did you use any method to measure the gap before operation? I mean, have you?
Yeah, so I do, what I do when we measure the gap is we take the baby down to radiology. We have an NG tube, a fairly firm NG tube in the upper pouch that we're applying pressure. And then we just inject the G tube site under pressure. So granted, you know, so we're not trying to stretch the lower pouch, but we're consistent in how we do it. So I think everybody has different ways. You know, some people talk about putting a scope up in the lower pouch through the G-tube site. Some people talk about putting a metal bougie blindly. I think that's not right, because I think you can miss the upper pouch, but we just rely on the contrast. So yeah, maybe the gap, maybe if I think the gap is 7 vertebral bodies, if I was able to stretch the lower pouch, it might be less, but we're consistent in how we do it. So that's how we measure it. And so if that gap, if with pressure on the NG tube and pressure, you know, a pressure contrast study, but nothing else, if that gap is over 4 vertebral bodies, then I call it a long gap.
Thank you so much.
Mhm.
Any questions from the audience? Okay, Steve, I have a technical question. You use your 3 millimeter device for the isolation of the upper and the lower pouch?
Yes.
Okay.
Yeah.
And your device don't cut. Your device.
Right. It doesn't cut, but it doesn't need to. I don't. So as you saw in the video, and I'm happy to, these videos are online, but if you don't have them, I'm happy to share it with you. But so what I do is I stay right on the wall of the upper pouch, or upper and lower pouch, and I'll grab the tissue that I want to mobilize. I'll seal it, and then I gently push up along the length of the esophagus, teasing those tissues off and the small blood vessels. And that way I don't risk cutting anything like, you know, a recurrent laryngeal or something that I'm worried about. And when you seal it, it very easily teases off. It's the same technique I use when I do a pull through for Hirschsprungs or imperfect anus. You don't need to cut anything. The vessels aren't that big. The tissues aren't that big. You just tease it off. And so I think it's a very safe technique. So it's a constantly, I'm spreading and then I'm grabbing tissue, sealing it and teasing it off. And that way you prevent any bleeding, but you also prevent injury to the surrounding tissues. And because all the energy is between the jaws, I used to use a hook to do a lot of this, but obviously there was significant energy spread with that. And so, and I don't know if I've injured any structures doing that, but I think this is much safer. And it also allows you just to get a much higher dissection.
I have another question, and after I give it to Mattioli. The second, Steve, is this. How many trocar you use for this procedure? 3 trocar, 1 for
3.
optic and 2 for hand. And when you use this 5 millimeter stapler, you use a 5 millimeter trocar in the right hand.
Yes,
yes, is correct?
Yes. Like when I do an H type, I actually put the 5 millimeter in my left hand, and that may be a better angle because you're coming from lower in the chest and it allows you to go more parallel with the esophagus. In the case I showed, in that case, I was able to come in with my right hand and go across. There was enough space. And normally when I do a type C, I put a 5 millimeter port in the axilla to bring in my suture. And that's because I just think it's a little more cosmetic to have the 5 millimeter port in the axilla as opposed to lower down on the chest. It's more hidden. Not that it's that big anyway, but if there's any question, I would put the 5 millimeter in my left hand so that I have more space to get the stapler in, because the stapler is 2.5 centimeters. The jaws are 2.5 centimeters, so you need a bit of space. And for instance, the last H type I just did, that baby was 1.5 kilos, was also born with a rectovestibular fistula. And so we actually kept that baby in the hospital. We diagnosed the imperfect anus first, and then baby didn't tolerate feeds, and we got a very nice study that showed the H type. And I let that baby grow to 3 kilos, so I'd have room to use the stapler and get the dissection.
Thank you very much, Steve. Girolamo.
Yeah, thank you, Stephen. Your presentation is always a very teaching power presentation.
Well, thank you.
I have some question, particularly some comment. First, I started experience with robotics, and I absolutely be convinced that the neck surgery to the chest is easier, minimally invasive approach than open approach in the neck, as you described, and you can see very well everything. So I'm really convinced that endoscopic procedure is better than open. My question is, you never experienced the flap of our upper pouch as described by Bagolan in long gap procedures? First question. Second
No,
question, you started speaking about gastric pull-up and through the laparoscopy and through thoracoscopy. My question is how you shape your stomach, tube or something else? And do you perform anastomosis in the neck or in the thorax between esophagus and stomach or esophagus and esophagus? Please.
so just I have very little experience with gastric pull-up, only a few cases, because we don't see strictures and things like that very often. We don't shape the stomach. We just so we mobilize the lower esophageal pouch through the hiatus from the abdomen. We pull it down, we staple it off right at the GE junction, and then we pick up on the fundus, the apex of the fundus, so the highest point after we've taken the short gastrics, and we attach stitches to that or a Penrose drain to pull that up. Then we dissect through the hiatus up through the mediastinum to make the tunnel, up. And then we make a neck incision and mobilize the upper pouch through that. And then we put a clamp down through the neck incision into the hiatus to grab our stitches or Penrose and pull the stomach up. And we do the anastomosis in the neck. I have no experience with doing, preserving the upper esophageal pouch, and doing the anastomosis in the chest. I by definition, all these kids reflux, obviously. And I guess I've always been a little bit worried about leaving that part of the esophagus. Also about if we have a leak this way, it's up in the neck and not in the chest, but I just have no experience with the other. So I get, it's, I guess, a bias of how I was trained.
What about the flap of the upper pouch? The flap of the upper pouch. As this.
I've never done the flap.
Okay.
Thank you. 4 questions. Leva, Tovar, Bianchi, Ricci Petitoni. Ernesto.
Yes. Hi, Steve.
Hi, Ernesto. How are you?
Short question. In case of complication, are there any contraindication to approach again with minimal invasive surgery? I mean, if you've got a day sense of anastomosis or other problems, anything that you suggest is not better to approach with a minimal invasive approach? And the second question, very short, is the mentoring process for this surgery. How do you feel, and which is the best way?
So in terms of complications, I think it depends on the experience of the surgeon. So I have gotten patients sent to me. I mean, again, we've had leaks, but we've managed all those conservatively. But I've had patients who've come from other institutions with terrible strictures. Some who've come with a fistula when they didn't have a fistula initially, or a missed fistula. And we've approached all of these thoracoscopically. But I think it depends on your comfort level. For me, I see it better, and I feel I have the technical skills to do that. And I would have a very hard time doing an open case now because I'm so used to seeing things so well. But I think you have to determine that based on your own experience. So in my hands, I would always approach it thoracoscopically, I think, or at least try. And, if you have to convert to open, then you convert to open. Mentoring is tough. One, I think you have to have enough cases so that you can you know, it takes a time to get comfortable with this and doing it. And so what I will tell you is that my partners all perform all of their esophageal atresias type Cs thoracoscopically. And now, and I work with them. We've had, you know, they've each had a couple long gaps, and we've done them. My most junior partner, one of the cases I talked about that we did in, I think it was in the end of November, you know, it was a pure atresia. We went in, did the initial mobilization, and then came back a week later and did the secondary surgery. She did great, but she's been doing her type Cs since she joined me 3 years ago. And so I think if it's a matter of skills, really, Ernesto, I think you know this too. If you have the skill set to operate minimally invasively, then you just transfer that to doing this procedure. It's sort of like the same question. How do you mentor somebody to do an open esophageal atresia? You know, if you see one a year, it's very hard to teach them the anatomy and the approach. If you see enough, then, and they have the skills to do it thoracoscopically, then I think it actually becomes easier, but the whole team has to be on board. If your anesthetist doesn't work with you to do this, then you may never succeed, because if they overventilate the patient so you can never see what you're doing, you'll never be able to do it. So it really needs to be a team approach. But I think it's skills rather than a procedure, unless you say, and there could be an argument for it that, you know, maybe you shouldn't be doing esophageal atresia unless you see 10 to 20 a year. You know, you shouldn't be doing it if you're in a center that does it once a year. And I think that's probably a reasonable argument, because I know all of you have seen complications from people from centers where they do 1 or 2 a year, and then when there's a complication, they send it to you to take care of it. So, you know, maybe we need to be a little bit smarter about that, although we all like to do everything.
Makes sense if we focalize 1 or 2 persons in the group that manage this type of.
Right.
Juan.
Yeah, Steve, I'm always mesmerized by the quality of the operations you perform thoracoscopically. I have a functional question. You have performed the anastomosis in 25 cases in a time span of 20 years or something like that. Certainly you have long-term follow-up of these patients. What's the quality of their esophagus? They have reflux,
so
stenosis?
I mean, and so again, about half had stenosis. One of them required up to 12 dilatations. I get a lot of these patients come from other places, so I get emails, and the families, you know, we do very strict follow-up for a couple years, and then they after that they tend to be followed at their home places. But I just got one of the first long gaps I did. He just graduated from high school and is going to be an engineer. He eats normally. Every once in a while, he, you know, feels something get a little bit caught, but not had significant problems. They're all tolerating oral feeds. So it's not perfect for sure. And some of them have, like I said, had reflux, got Nissens. But in general, I think they have a very good quality of life. And maybe we've just been lucky. You know, I consider the fact that we've only had to do one, only been able to not get one together, that's luck more than skill, I think, for sure.
Thank you.
Adrian.
Well, my question was exactly the same as Juan's, I'm afraid. So you do have a fair incidence of stenosis that requires dilatation? Yes,
for the long gaps, absolutely.
Right. And you consider that an acceptable outcome, a necessary evil?
Yeah, I do.
Okay. The last bit to the question is in relation to diet. You partly answered it already in your answer to Juan. Do these children have to alter their diets? Do they eat normal solids? Are they having to drink large amounts while eating? What is the quality of the food they can have?
So I think most of them eat relatively normally. I always tell them, and honestly, it's a good question. I should ask some of the older patients. When they're younger, I always tell mom to make sure that they always have something to drink to help wash things down. I mean, I don't think this is a normal esophagus. I don't think there's normal peristalsis. I don't think the area of the anastomosis is totally normally functioning, but it acts as a conduit to get things down. But most of them, you know, by what they've told me, have a relatively normal diet. Now, again, you know, I don't have a huge series of these long gaps. Certainly the type Cs, we have much more, we have many more patients, and I feel like they all, you know, every once in a while we'll have a 7-year-old who comes in and he's got food, a chunk of meat stuck in his esophagus, and you go pull it out and you can't really see a stricture, but you know his esophagus doesn't work right. And that, if you ask them detailed, they'll say, yeah, every once in a while I feel something get a little caught and I wash it down. But you know, I think considering the alternative, at least for us, which is to do some kind of interposition, I think it's a good trade-off.
And is the upper pouch in these who have these blockages large as compared to the lower pouch beyond your anastomosis?
Not as they get older. Initially, yes, but
Okay.
it tends to equalize.
Thank you. Congratulations on your thoracoscopic skills.
No, thank you. It's great to see you.
And you.
Giovanna, il tuo intervento, il tuo commento?
Hi, Steve.
Hi, Giovanna.
Hear always from you. You are always a great teacher. I have some questions. And first of all, I would like to know if you have a special skill to treat a difficult problem, recurrent fistula. And the second question is, what is your attitude about tracheopexy? You know, there is also colleagues as David Van der Dies, who suggested also to perform the treatment at the time of the first surgery. What is your opinion and what is your attitude?
Yeah.
Thank you very much.
In terms of recurrent fistula, the ones I've seen, we've approached thoracoscopically. I can't remember exactly the number, but I've had one failure doing that. Again, those were patients who were sent to me from other places. We've only had one recurrent fistula in our series. That was one of my partner's patients, and we were able to go back in and repair it thoracoscopically. The last one I did, actually, I was able to use it was like a 20-month-old who she had problems for months and no one had diagnosed it. They finally saw it, and we went in and I was able to divide it with the stapler, and then I rolled the esophagus a little bit to separate the staple lines, and she had a little bit of a leak, but it resolved, and she's done quite well, and she's back to full oral feeds now. In terms of tracheopexy, you know, I think there are some indications for it, but I think doing it in every procedure is wrong. You know, again, I don't have the biggest series in the world, but if you take all these cases together, I have about, you know, 180, 190 cases. I've done, I think I've done 4 aortopexies, and now I've done a couple posterior tracheopexies, but it's well less than 10% of those patients need that, if that, you know, maybe even 5%. And so to routinely do that, you know, if I always say, if, you know, if God had wanted us to sew with ski needles as opposed to round body needles, all needles would be ski needles. Well, if God had wanted us to have a fixed membranous trachea, then he would have fixed it to the spine. You know, I think there's a benefit to having a membranous trachea that moves. And so I think doing a posterior tracheopexy in every case is not appropriate. I think there are some cases where it's helpful, but I would rather have a patient prove to me that they need that.
Thank you, Steve. Any questions?
Thank you very much.
Okay. Thank you, Steve.
It's great. Thank you.
For
it's
us,
great
it's
seeing
an
you all.
honor. It's a pleasure. Bye.
Oh, mine. All right.
Bye.
Take care.
And now Steve speak about the Paskowski technique, and we have my good friend Darius. Please, you want to show your technique for elongation of the esophageal pouch, please.
Good afternoon to everybody. Nice to see all of you, all my friends. I'm very happy to be with you. Unfortunately, we cannot meet together personally, but maybe the time comes back and we will meet again. It's a great honor to speak to you, especially that I feel like a student, especially for Steven Rothenberg, and I got a lot of his knowledge and his experience. So just hope you can see my screen.
Yes, we see very well.
Okay, so I will talk about the internal traction suture, that is technique that we developed at our department. But of course, the idea of this technique comes from other traction techniques, especially Fokker technique. The picture that is you can see, this is our new hospital that we moved last year. So right now we are in a completely new department. So I'm on duty today, so this is why I am not in a suit. And so I will talk just only about type A and type B, because this is just by definition the long gap that we use at our hospital. So the internal traction, the idea of this technique is just to put the suture between both esophageal ends and to keep them in traction for a couple of days. At the beginning, it was almost 1 month. Right now, it's 2 to 4, 5 days. It depends just on your logistic. And we connect it with the sliding suture, and we put clips just to spread the force created by the suture and to prevent any leakage and tissue disruption. So my personal experience with esophageal atresia right now, we started in 2005 with thoracoscopic techniques. So right now it's more than 200 newborns operated not only in Poland, but also in many other countries, also in Italy, in Rome and Brescia. And as you can see, there are all kinds of all types of esophageal atresia, but I will talk only of type A and type B. And internal traction we used in 42 cases. And this is our opinion, that if you talk about cervical esophagostomy, should be always avoided only as the last resort, reserved only for very, very complicated cases, because it changed completely our procedure. So this is just a short video of our first cases that we use with internal traction. You can see that this is a dissection, the lower pouch, the upper pouch, you can see the distance. So this is just a suture. We use Eti-Bond braided non-absorbable suture 2.0 and put it under the tension. Then we put clips. We change it a little bit, but it was our first technique. You can see the distance. In the same case, it was 1 month later. You can see a lot of adhesions that needed to be separated by electrocautery. And as you can see right now, the tension, there's almost no tension. Both esophageal ends overlap each other, and this is a good sign to make the anastomosis. So the question was, with our experience, how long is optimal to waiting between procedures? And this is our first case that we had waited a little bit shorter. The first procedure you can see on the left video, the distance was almost 3 centimeters. And this case was kept without gastrostomy for 8 days. And at the second stage, we are going to put the gastrostomy. However, after mobilization of both esophageal ends, you can see that both ends are overlapping each other. So it was possible to create the anastomosis without any gastrostomy. So with this experience and other cases, you can see the first stage here and the distance. 5 days later, another one, the second stage. And here you can see just the final step, the third stage after 10 days, and it was possible to do the anastomosis. So we changed our strategy for long gap. And right now we always do, as Steve Rothenberg told us, we always do a preoperative bronchoscopy just to check for the fistula. And it gives us a lot of information about the trachea, about any tracheomalacia, and other malformation. We always look for any malformation of the larynx. That's very often that we have, sometimes we can find the first degree of the schisis of the larynx. So we do a thoracoscopy as early as possible. It depends only on when the patient arrives to our hospital. So we do no gastrostomy, only for complicated cases. And we are using 2 sliding knots. And the second stage is every 5 days, but the last case we performed after 2 days, so it also works. So the question is still open. This is the same film video that Steve already presented, but just to explain you some things. You can see that the operative field is completely clean, without any blood. And just to say, we are not using any cautery. There is just only blunt dissection. Can you imagine? There is no hemorrhage. If you stay in the limits of the tissue, of the structures, there is no hemorrhage. This is just after almost the end of operation, no suction, no cleaning. It looks like if you just use only blunt dissection. And as you can see, the azygos vein is untouched, so we never cut it. I even joke that I don't know how to do it. So you can see this is a sliding knot. Because the knot is locked within the clips, so we are using 2 sliding knots. So this is a change in our technique, because right now we put clips before starting approximation, and it led us to use a bigger tension. So you can see just at the beginning and just at the end of traction, and the same case after 5 days. You can see still no cautery, just only blunt dissection, of course, because right now there are some adhesions, so there are some hemorrhage, but it doesn't need any suction. Opening of the upper pouch, you can see that you can see all the structure, mucosa and muscularis, the lower pouch. What's important, don't cut this internal traction, because it keeps both esophageal ends together. If you cut it, they go away, and it's really very difficult to bring them again together. And what's very important, if you are using this sliding knot, you can use it again if you need to do another one stage. So you don't need to put new sutures. You can open such a sliding knot and use it again. Okay. Another one case, look for this very small, tiny lower pouch that is almost just above a diaphragm. You can see the distance between the lower and upper pouch. And after careful mobilization, you can see that both esophageal ends are brought together almost for 2 and 2.5 centimeters. And the same case 4 days later, and the final anastomosis without any gastrostomy, So our experience, internal traction was for 32 cases. Unfortunately, 3 cases died. 2 cases had cervical fistula created because of perforation and complication. It happens, unfortunately. However, completed surgical treatment with final esophageal anastomosis was in 37 cases. Some of them were done in open fashion. All of them were done in other departments that I started with operation. However, the final operation was done in open fashion. One was complicated by the huge leakage that was, by the leakage, it was leakage that had no clinical symptoms. And when we tried to do the second stage, the pleural cavity was completely obliterated. So this was why we had to do a convention. However, we were able to put both esophageal ends together. And as you can see, majority of cases were done in 2 stages, some of them in 3 stages. 1 case required 6 stages, however, completed by thoracoscopic approach. So this is the picture of this baby that had 6 thoracoscopic procedures. So can you imagine to do 6 open thoracotomy? So at the conclusion of my short lecture, thoracoscopy should be considered in each case, but of course the experience in neonatal endoscopy is needed. We need to master and find the optimal technique still, and thoracoscopic approach, this is my opinion, will change the way we manage the long gap esophageal atresia. Thank you very much for your attention. Thank you.
Thank you very much, Darius, for your presentation. Your experience is very important. And now, if you agree, we continue with Olivier Reinberg and Adrian Bianchi, and after we start the discussion. Is possible for you, Darius?
Yes, of course. Yes, of course.
Okay. Adrian.
Okay.
What you learned in your experience in the treatment of your long gap esophageal atresia?
Allora, si vede, Mario?
Non ancora.
Perché?
Oh. Prova a uscire e a rientrare.
Uscire completamente?
Sì, uscire completamente e rientrare.
Proviamo un'altra volta questa.
Perfetto.
Si vede o no?
No, non ancora. Ecco, adesso sì, Adrian.
Ok.
Adrian, perfetto.
Okay.
Metti in modalità presentazione e siamo ok. Perfetto, grazie.
Adesso siamo su slide 3. Okay. Okay, so having listened to the previous talks, this one is a little bit different, and I'm sure I will convince no one. I don't want to discuss lots of numbers. I want only to talk to you about what I learned during my training time and then during my time as a consultant, and why I changed my ways. I call my approach reconstruction respecting the physiology of the child. You will notice that I'm putting emphasis on the physiology of the child and not on the esophagus. The book published by the TOF Association here in England was written to inform the parents. And in the book, it shows a blocked, very dilated upper pouch. It shows a gap of around 3 vertebral bodies. It shows the fistula, and then it shows the lower pouch, which is narrower, more close to normal, but narrower compared to the very large upper pouch. Momento. The book informs the parents that they need to get to recognize obstruction when the children are eating, because they have to expect that food gets stuck in the esophagus. Food getting stuck in the esophagus is a lifelong hazard for patients with esophageal atresia. And in fact, John Puntis, who is a gastroenterologist in Leeds, writes that meal times, eating, is a major problem for parents of children who will not eat or who cannot eat. And these are important issues which we didn't touch on today, because we're supposed to be concentrating on the long gap as opposed to every aspect. But many children will not eat, and we have to ask why not. The operative surgery textbook by Louis Spitz and Arnie Corrin, which also Steve Rothenberg referred to, on the cover shows an upper pouch that is blocked, not so wide, but certainly wider than the lower pouch, which is largish, shows a narrow gap of around 1 to 2 vertebral bodies and a fistula. In this book, it proceeds to explain to us how to do a large upper pouch to a narrower lower pouch circular anastomosis. And very rapidly in the chapter, it moves on to tell us how to make an anastomosis under tension. The book for esophageal atresia informs the parents that sometimes surgeons, for whatever reasons, and we have heard several today, choose to delay the anastomosis. And then it says to them, but invariably there will be tension on the repair with a delayed primary anastomosis. It moves on because it feels that it is important for parents immediately to understand that the consequence of a circular anastomosis between the very large upper pouch and lower pouch very often is a severe stenosis, which will then require repeated dilatations under general anesthesia. In a more recent publication, in 2019, David van der Zee explains that esophageal stricture is a very common complication in 80% of patients. 40% of these are clinically very significant. And he says that the risk factors include poor surgical technique, such as excessive tension of the anastomosis, and patients with long gap. And also, he mentions the incidence of severe gastroesophageal reflux that occurs in such situations. In fact, he goes on to quote the incidence at close on 63% of cases who have severe gastroesophageal reflux. The etiology of the reflux could be congenital, but largely is the result of the surgical effects, and particularly surgical techniques that are used to preserve the native esophagus and which favor the onset of reflux. And these include a short esophagus, which is the result, an opened angle of His. Quite often, the stomach is dragged into the chest, and denervation of the esophagus by very extensive mobilization of the esophageal pouches. We have heard a lot in the previous talks about how to mobilize extensively the esophagus. I worry. What is the impact of atresia? The impact of atresia is a wide dilated variable but dilated upper pouch, which initially is obstructed, of course. And then even if there is not, if you manage to do an anastomosis and there is not a stricture at that point, you see there is severe delay in emptying of this esophagus. I will not speak about the trachea, that is for another day, because there is a lot to say on that. The impact of surgery, even if there is not a fibrotic stenosis, is what I call a funnel effect. You eat, you have to drink a lot, you have to modify the type of food that you eat. It passes very slowly as long as it is liquid enough, and very often you will spill, you will aspirate, the baby will get repeated chest problems. If you get a fibrosis, of course, there is a hard obstruction and you try to dilate it initially. But the effect on eating, particularly when it comes to solids, is that there is a total block and the child is unable to eat. So the impact of surgery on this wide dilated upper pouch with a short is a short esophagus, a tight circular anastomosis, disruption of the angle of His with gastroesophageal reflux in a denervated esophagus, a totally dysfunctional esophagus. And what do we do for that? We put another obstruction at the bottom end of a totally dysfunctional esophagus, so-called control the reflux. I want to pass to another consideration. If you try to forget esophagus and think when you go to buy a new car, okay? Here is a new car that you go to buy. It's called Latoff, okay? And they say to you that this car was manufactured with the technology of before the 1970s. Joan knows that technology. I know that technology because we are about the same age. This car has problems with its tires. They have to be pumped very frequently. The engine is chronically a problem and does not start. You have to take it to hospital regularly for repeated adjustments to the engine. And even more so, the paintwork is very poor and there are many scars on it. Will you buy such an esophagus? Will you buy such a car? Well, I leave you to answer for yourselves. I certainly would not consider buying a car like this. So why do we accept on the part of the patient, on the part of the family, as inevitable evils, the need for dilatations, major modifications in food, drinking a lot, severe chronic esophageal dysfunction, reflux, Barrett's esophagus, repeated chest problems, failure to grow? Why do we accept this on the part of the patient? The patient has no chance to say, yes, I like this, no, I don't. But we accept that this is the routine. Why? Because it is in every book and paper, and therefore it must be right. Before 1943, all patients operated for esophageal atresia died. 100% mortality. Should we have accepted that as the outcome of surgery for the esophagus in esophageal atresia? No. We have to try harder and we need to evolve better concepts. This is what I have tried to do in my own life, and I began in the late 80s and through the 90s until my retirement in 2010 to change my concept of how I manage esophageal atresia. The TOF book explains to the family that babies start to feed at birth. They learn what is food, how to swallow it, and what is its taste. And by 3 months, they then begin to also accept and explore new tastes and smells. At birth, not at 8 weeks, not at 12 weeks, not at 4 to 6 months. That is what we accept as a necessary evil. It doesn't have to be. So for me, normal physiology of the newborn says that early oral food is essential because the brain has to learn what is food, what is taste, how to form a bolus, and how to swallow it, in order to avoid refusal of food and food phobia. You know, you see this problem also in other situations. For example, the shortcut children who are drip fed with a tube and are not and do not eat regularly by mouth. When they get a transplant and they have bowel that absorbs, they will refuse to eat because they don't know what is food and they don't recognize its taste. It is very important that babies from early time, preferably at the breast, not necessarily by bottle, get oral food intake. My management, therefore, respects neonatal physiology and guides what I do. If I believe in this, there is no place for delayed repair. Now, we have always been taught that the best tissue for esophageal reconstruction is the native esophagus. As long as you don't get a tight stricture, 80%, according to David van der Zee, or a functionally obstructed, a dysfunctional funnel type esophagus. I then changed my way to trying to get rid of the big dilated esophagus by tailoring it using a large upper pouch and long upper pouch flap, which allows me to narrow the upper pouch, and then I turn it down. It is full thickness, fully vascularized, and I insert it into the opened out fistula and esophagus. This allows this upper pouch reduction, lower pouch augmentation, allows me to have a longer anastomosis. So even if there is some leak or such like, it heals without stenosis. An esophagus of more uniform diameter all the way down. And in this way, I have been able to cross up to 4 vertebral bodies without tension on the esophagus. I don't want to go into figures. We can come back to this if you want to examine it further. But there was in 58 patients, 1 to 26-year follow-up. There's early morbidity in the early time when I was still learning. There was some more problems, but they were with anastomotic leak, but we treated them with chest drain. There was no stenosis once it healed. Recurrent TOF, we had 5. One I needed redo for replacement. So I learned from these and we didn't have any more problems after that. Esophageal stenosis in the whole group, 2. Dysmotility, 2. Reflux, 5. So it's not perfect, but it was certainly better. Here we did 2 redo anastomosis. The dysmotility here led to a couple of episodes of food bolus obstruction. And the reflux, we did 2 fundos, and I was very unhappy with that. All eat unrestricted normal diets. There is nothing that we say to them they must not have. But Mario asked us to speak about what is long gap and to try to give him a definition of what is long gap. You have seen type A here. This is obviously a long gap, and it is what in the book is quoted as long gap. In fact, in the operative surgery by Spitz and Koran, it suggests 3 centimeters or 2 to 3 vertebral bodies as a definition. If you do, as I do for all cases, tracheoscopy, because I want to see the larynx, I want to see tracheomalacia, I want to see the number of fistulae, etc. Before I start, then sometimes there are alarm signs which tell you that the gap is going to be rather longer than routine. And this is if you see a short upper pouch finishing in the neck, and if you see that the fistula enters at the carina in between the bronchi instead of up on the back of the esophagus. what is long gap? My definition of long gap has ended up saying wherever I cannot reconstruct to a normally functional esophagus, an esophagus that allows the patient to eat without any problems and without any restriction, an esophagus that is where I can do a wide tension-free primary anastomosis, where there is no reflux and I do not have to consider the necessity, if such it is, for fundoplication. So if I cannot satisfy these, then I am dealing with a gap which, to my mind, with the principles of physiology of the neonate in my mind, is not bridgeable by pulling the ends together under tension. Best tissue for esophageal reconstruction, we were always taught, is the native esophagus. And as such, I have looked at and tried to explore the concept of lengthening. I went to see Kimura and others in my time. And all the time I was using my pouch and exploring how far I could go with the flap from the upper pouch, and I could reach up to 4 vertebral bodies. So covering 4 vertebral bodies is not a problem. Beyond 4 vertebral bodies, then for me it becomes a long gap. But if I cannot bridge that, then that is a long gap. Sometimes, if I have a very wide esophagus, I can make a large wide flap, and I could use tubularize it and use some of the flap to actually lengthen my esophagus, avoiding having to dissect the lower pouch, denervating it and pulling the stomach into the chest. I tried Kimura's procedure, spoke with him, saw some of his cases, but I did not like the several scars on the chest, and worse than that even was the quality of the so-called lengthened esophagus, which was thick, fibrotic, rigid, and often not so wide. So I don't counsel it. As far as the Fokker technique, which we have already heard about, I spoke with John Fokker, and when I asked him why he has so many complications, he told me that was for me to work out. But it is based, according to Jack Fokker, on the idea that if you pull on the pouches, they grow. Now, I don't know if Darius and David believe that their esophagus grows by pulling on it in 2 to 5 days or 5 weeks, or whether what the lengths that they get are just from mobilization. But Jack Fokker insisted that the esophagus grows. So he used to put traction on the lower pouch for 10 days, and he would go back into the chest and put his sutures back again and continue pulling. But at 10 days, he would then do the anastomosis, and he had a very high incidence of problems, as you saw, with breakdowns, with strictures requiring dilatation, with reflux, because the esophagus is too short. And I asked him if he believed that by pulling on the esophagus it grows, why not continue to pull for a few more days until you have sufficient full length of esophagus, and then do your repair? And he said to me that he could only get his anesthetists and neonatologists to accept 10 days, and they would not allow to go beyond 10 days. Well, I don't see that as a reason. We heard from Pierre Bagolan last time about magnetic traction following Hardy Hendren's great big machine in the 70s that used magnetism. Very interesting, but I don't know how wide a gap it is possible to try this in, whether it actually gets to growth or just stretching of the esophagus, and how long a time is necessary. So what sort of gap can you bridge? But it is interesting. So best tissue for esophageal reconstruction is the native esophagus. This is what was drilled into me in my training years as a young surgeon in Liverpool at Alder Hey Children's Hospital. I say this is correct as long as you can eat easily, you have no aspiration, and you have no reflux. If you cannot satisfy those, it is better, to my mind, to have a better functional esophagus made from something else than a poor, dysfunctional native esophagus. And I will therefore abandon that esophagus completely. Here is an obvious long gap, as you can see. Even for these, therefore, the principle of neonatal physiology guides my reconstruction. I want the baby to eat very early and immediately for brain learning for food. I will place a wide right, not left, right esophagostomy. It is important because that allows me to feed the baby at the breast or by bottle immediately with full feed of normal variety of food for the baby's age. And then there is the gastrostomy, and I collect what comes out of the esophagostomy and I pass it down the gastrostomy. And in this way, I am allowing brain learning while I wait for my next reconstructive technique. Again, if I believe in physiology, I have no place for a delayed repair without an esophagostomy. My techniques for replacement, therefore, of the esophagus are jejunum, wherever it is possible for me to do it. This is because here is a loop in 2 stages on this occasion, a loop of jejunum mobilized still in the abdomen after stage 1. I like jejunum because it is actively peristaltic. It allows me, therefore, because it is anti-reflux, being peristaltic, isoperistaltic, it allows me to replace early, even within 3 months. And so the baby can carry on with learning what is food, because once it is in place, he is feeding normally without reflux. As regards long-term problems, I think many of the audience can give a better answer than I can, because many I have done in Italy and several other places, and I don't see them. But I don't get from you complaints. More often, I get asked to do some more. Ernesto in particular can perhaps give us a view on this. Here is another similar case with a loop, which then goes through the posterior mediastinum to the neck. The anastomosis is in the neck. Here you can see one of the children happily eating her pizza without problem. The problem with jejunum is that blood supply can be difficult. So whenever I approach a substitution, I try jejunum, but I have as a backup the possibility of a full stomach. Here is a child who had a gastrostomy, didn't have any traction, but was being fed regularly via gastrostomy and through the esophagostomy. And you see the esophagus has not altered at all over all this time. Prempuri used to say, you just feed them with gastrostomy and the lower pouch dilates and increases. Well, this is what I used to find, so I could not confirm what I was being told. Here you see the stomach in the chest, the anastomosis is in the neck. Posterior mediastinum. Okay, if at the end of the day I cannot use jejunum and for some reason the stomach is not available, which has an excellent blood supply, of course, then I have to fall back on colon and always through the posterior mediastinum. The problem with stomach and colon is that they void by gravity, they are not peristaltic, and the child has to be able to maintain an erect posture when feeding and afterwards, otherwise they will aspirate. So we did 72 patients, not necessarily all long gap, but also for failed previous surgery. 25 jejunums, 18 one stage and 2 in 2 stages. These were the first ones in order to try and improve the blood supply. Then I found we could go at 1 stage. There was 1 cervical stenosis, which required revision of the anastomosis. There was one loop necrosis, and I replaced that with the stomach. And for 3, I didn't manage to get a viable loop through at the time of surgery, and I converted to stomach or colon. There was no mortality in these cases. Total gastric transpositions, in the way Louis Spitz used to describe it, we have done 36. 3 of the 36 have transient dumping, and one child, I don't understand why, but didn't dump for something like 10 years, more than that, 13 years, and then at age 14 started dumping again. And I don't know how to correct that. One cervical stenosis that required revision, this is stomach, and one child had such a large stomach that he would take Coca-Cola and the gas in it would distend the stomach and collapse his lung. So I had to go back through the chest and do a tailoring of the stomach in the chest, and he has never had any problem since. Of this group, we had 4 dead, 2 from aspiration. Why? Because I did 3 cases early, before I realized that it was so important that they had to be sitting up, and because drainage was only through gravity. And 2 of these died with aspiration, and 1 got a stenosis that I revised here, and he survives well without problem. Transverse colon, we have 11. 2 had a stenosis at the neck, which needed revision. So I need to work better at my anastomosis. There is no mortality. They all eat unrestricted normal diets. I have no information regarding Barrett's, I'm afraid. I finish by saying to you that children with esophageal atresia, if they were able to speak to you, will ask you for the ability to breathe freely, a subject we can discuss another time related to trachea. They would like the ability to eat and to swallow easily and to enjoy their food, and they want to grow normally. And then they don't want to see you again. They don't want to come for dilatation after dilatation after dilatation. They ask you for quality of life. Here is 2 children who had a 30-centimeter jejunal replacement. This gentleman lives in Athens. This young lady is French, and here is her jejunum, and she eats anything and everything that she wishes. They don't ask you for a native esophagus at all costs. They ask you for quality of life. Thank you very much.
Thank you very much, Adrian, for your presentation. It's very interesting and impressive experience. And now, Olivier. I work. Olivier, okay. Your experience. The discussion is after the presentation of Olivier Reinberg. You are ready, Olivier? Yes, we see your laptop.
Well, can you hear me?
Yes, you see very well and you hear very well. Please.
Great. Good afternoon. It's a pleasure to be with you again. And it's my pleasure to say hello to many very good friends. I will talk only about long gap esophageal atresia. As I've said, as Juan Tavares said, I have a little shorter experience than he has because I start only in 1980, 4 years later, as chief resident with Noël Janton. And I have to say that I was trained partially in Quebec, in Saint Justine Hospital in Montreal. And you may know that in Quebec, there are far more esophageal, all bowel atresia than anywhere else due to consanguinity, because they have a lot of bowel atresia. And I would say that in Montreal, you can perform 3 or 5 more times esophageal atresia than anywhere else. The other thing I want to say is I was interested in the esophagus and the physiology of esophagus. And I listened to what Juan Tavares said, not only because he's a very good friend and an example for me, but also he's a mentor, as Arie Bensoussan in Montreal and Yves van den Plas in Brussels, about esophageal physiology. And all what I will say in a little while is just underpinned by this. So first of all, what's long gap esophageal atresia? We don't know. We have no precise definition. As it has been said, it's between something like 3.5 centimeter to up to 6 centimeter. Arnold Coran said more than 6 centimeter. More simply, I would say that the long gap esophageal atresia is the limit of your experience. I mean, when you are a young surgeon, when you are a senior resident, a 3 centimeter esophageal atresia might be something difficult for you. And then with time, you improve your experience and you're able to put end to end the gaps with longer and longer distance in between the two ends. So the long gap is something in between 3 centimeters up to something else, but it depends to your skills. When do you have to think about a long gap? Because before starting operating, you have to think about this. As it has been said, the long gap is far more frequent in type A or type B, type A without fistula. And another thing I would say is when you go to see the prenatal ultrasounds, look if you can see the stomach. If you don't see the stomach, be very careful because it might be a double-blind esophageal atresia and then a long gap esophageal atresia. Then post-birth, you go and see the baby which has been born and you see that he has a depressed abdomen, or on a total X-ray, you see that you don't have air in the bowel. Be careful, this might be a long gap esophageal atresia. And if you add to this that he has no throating at the mouth or minimal throating at the mouth, then be careful. Don't have to start for a usual esophageal atresia. This might be a long gap one. So what to do? How to manage this? You've heard many different ways, and Professor Lima asked me to say about my experience. My experience, if I see that the anastomosis, the primary anastomosis, is not feasible, wait. Most esophageal atresia are not surgical emergencies. Then you can wait to think, can I do it? Take some advices and plan what will be the next step. So take time to investigate how long is the gap and see if you can manage it. So why should we wait? Because we have a spontaneous lengthening that Juan Tovar has advocated, and then a possible delayed anastomosis may make an anastomosis feasible which was not at birth. It takes weeks or months to lengthen spontaneously. Pascal Delagozie has written that about 1/2 can be done between 2 to 4 months. And Prempuri has shown that the maximal lengthening, spontaneous lengthening of the upper pouch is between 6 to 8 weeks. But all this remains true as far as the esophagus, mainly the upper pouch, hasn't been fixed by scarring process. Means that if you have touched it, if you have done something aggressive, if you have adhesions, then the spontaneous lengthening diminish and maybe we don't have any lengthening of the upper pouch. This is an example we had. It's not a special one I've chosen for this lecture. This little girl was born with a 6.5 defect in between the two gaps. And without doing anything, just waiting, at 4 months, the length in between was a little less than 3 centimeters. And of course, we were able to perform an anastomosis without any tension. So how to manage it? If primary anastomosis is not feasible, we wait. But we need a gastrostomy, because if we have to wait for a few weeks, as you've seen, about 8 weeks, 6 to 8 weeks, then 6 to 8 weeks of parenteral nutrition is something quite difficult with a lot of complications. So we have to perform a gastrostomy. Be very careful. These cases have a microstomach, so it's a very difficult gastrostomy. And most of you know that I'm doing a lot of laparoscopy and thoracoscopy. Well, I've been doing a lot of laparoscopy and thoracoscopy, but I think that this gastrostomy is not advisable for laparoscopy. You have here a picture where you see a balloon in the stomach of such a long gap esophageal atresia. The balloon is inflated by 2 milliliters and it fulfills the whole stomach. So it's quite difficult to perform the gastrostomy. Sometimes we don't have to inflate the balloon, and it's difficult to fix the gastrostomy to the abdominal wall. So this is not an easy gastrostomy. This is probably one of the most difficult you may do. Then to perform the gastrostomy, we need an anesthesia. And I agree totally with what Steve Rothenberg has said and some others, is that we need, in those cases, an endoscopy. I would say a pan endoscopy means that in both tubes, the esophagus and the trachea. I would say that I perform a pan endoscopy in all cases of esophageal atresia. But for the long gap, the presumed long gap esophageal atresia, this is mandatory. If there is no fistula, then don't do anything on the esophagus. Just wait. If there is a fistula, then we have to ligate the fistula. Usually the fistula is at the upper pouch, but I've seen one case of double fistula. Of course, it can be done by thoracotomy or thoracoscopy, but as I've said, the lengthening of the spontaneous lengthening of the esophagus is impaired by scarring process. So if you do it by thoracoscopy, you have less scars than if you do it by thoracotomy. So my favorite approach would be to ligate the fistula by thoracoscopy and then wait. And then during that step under anesthesia, where we perform the gastrostomy and the endoscopy, we can have a tube in the upper pouch and do X-rays to be able to compare what's going on within the following weeks. So what should be avoided? My belief is that we should avoid a cervicostomy, because if we perform a cervicostomy, we have no possible elongation of the upper pouch. It impairs the spontaneous lengthening, it fixes the upper esophagus. But I agree with what was said, that the child has to eat since the very beginning of his life. And that's why we use sham feeding, means that we have the child sucking, and then we have a replug in the upper pouch, and we are able to suction what he is eating. Of course, we don't give milk, because if milk goes over the upper pouch of the esophagus into the trachea, it's devastating for the lung. We use just glucose or mostly dextrose, which is not that dangerous in the lungs. What should we avoid as a replacement as an early procedure? Those who know me knows that I've performed myself more than 300 esophageal replacements in between 1988 and 2014. But I have never performed a replacement for a so-said long gap born in Lausanne. I've done for cases referred from elsewhere, but if you manage it, as I've said, we don't need a replacement. And in my opinion, I think that this is unacceptable, mean to perform a colonic interposition at D2 for 2 vertebrae. This is not fair for the child. This is not a good process. What should be avoided, Ken? No transthoracic elongation like the Fokker technique or the Kimura or others. Why? We've seen that with the Fokker technique, at least, as Juan Tavares said, we have 4 surgical procedures. We have adhesions. In fact, when I went in Montreal where they start doing Fokkers, and when I returned to Montreal, another case I was referred, in fact, there are 4 more procedures in the Fokker procedure because we have leaks, we have infection, we have the tear of the threads on the pouch, and then we have to replace them and so on. So we have redo thoracotomies or thoracoscopies, and then of course they sticks the esophagus to the mediastinum and so on, and makes the anastomosis very difficult. And of course, as you've seen with what Juan Tavares said, we have poor results. I mean, not better than delayed anastomosis, because of course, long gap esophageal atresia is a challenge, and we have a lot of problems that we will see in a short moment. I don't think that we should use the lengthening techniques like the levadetis or others. The levadetis is that technique which was also called the telescope, where you cut around the muscular layers of the esophagus. And of course, the mucosal layer can slip inside the mucosal layers, and it's very easy to lengthen. But we have a piece of esophagus without any muscular wall, and this leads to severe scarring process and subsequent strictures. And those strictures are far more difficult to dilate than the stricture related to the anastomosis. And I will show you later the problem of the esophageal dysmotility related to that. And of course, the worst thing is to add the elongation with the lengthening technique, means the traction and the levadetis. Now we'll give you some tricks how to bring the long gap end to end. As you remember, I was among the first one the same year as Steve Rothenberg to perform an esophageal atresia by thoracoscopy by the year 2000, as also C.K. Young. And we were not, we need some good skills to approximate the 2N, and we have to find some tricks. And we found a trick that we have been using for quite a long time for the long gap esophageal atresia. And that trick is a kind of Fokker, but transient Fokker. We use threads to bring the 2 ends together so we have no tension on the suture. So you take a thread, not too small, I mean 2030, monofilament that it slips very easily through the wall. The upper pouch is not a problem because it's very thick, but the lower one has a very thin wall. So you need to have one bite from a diameter, from one end to a diameter to the other one. And then you go out from the thorax, and with 2 mosquitoes, you approximate the 2 ends, and then you were able to perform the suture. And that's what we did for the long gap esophageal atresia. But I have been shown another technique which was developed by François Beckmer in Strasbourg, and I can tell you that it works. You ask the anesthetist to come with a Fogarty catheter, after being placed a thread like the one I've shown before. It has to be a U stitch with a monofilament, and this narrows the lower pouch. Then you inflate the balloon. You don't tie it, of course, because you may have it here. And then your balloon comes on the thread, and you're able to ask the anesthetist to pull the lower end up and to realize a suture without tension. And I can tell you that this very clever trick that Francoise developed in Strasbourg worked quite well to bring the lower end close to the upper one. Now the complication of those techniques, because we always have some tension on the long gap esophageal atresia, even if you wait. You have a leak, leave a suction tube for a few days in the esophagus. This minimized the leak, the flow of saliva, which comes through the fistula, and then it closed spontaneously within a few days, up to 2 weeks. We never had to reoperate a fistula, and of course, oral feeding is delayed, but you can go on with sham feeding with a suction in place. Even with such a large leak like this, it closed spontaneously, just have to wait. The second complication is the stenosis. I would say that, as Adrian has explained with the funnel model of the anastomosis in esophageal atresia, the upper pouch is always large and the lower one is very narrow. And there's always a difference in caliber, and we have to deal with that. We delay it only if it persists after a few weeks, but of course the feeding takes time, and we have to teach the mother to feed the child very gently with small amounts, and the rest is given by the gastrostomy. And then, as far as we increase the feeding per us, we decrease the feeding per the gastrostomy, and it takes a few weeks. If it lasts for weeks, and I don't want to say how long, I don't know, we have to delay it. Then should we delay it with a balloon or with Savary? And you know that Savary was our boss, ENT boss in Lausanne. So we're all using the Savary tubes in Lausanne, but for an esophageal atresia. Because with a Savary tube to dilate, we push the upper pouch down and we have tears. If we use a balloon dilatation to dilate a stenosis after an esophageal atresia, we have a radial opening of the esophagus without pulling down the upper pouch. And I prefer to use a balloon, even in Lausanne, where Savary came from. Now, the third problem which has been advocated is the esophageal dysmotility, which is a very common long-term problem with children with esophageal atresia and or fistula. It has been demonstrated in many, many cases. And I would say to Adrian that it's not only in the lower part of the esophagus, it's not after the surgery, but it has been proven, I have no time to go on with that, but even in the proximal esophagus, before surgery, we have impairment of the motility of the esophagus. For instance, as Juan Tavares said, and as he has been doing, we've been studying the motility of the esophagus. This is, for instance, the pH metry of an esophageal atresia, not a long gap, this one, with the two probes pH meter, one in the upper pouch and one in the lower part of the esophagus. And you see that we have a normal clearance in the upper esophagus and a very poor one in the lower with reflux than more than 5 minutes. So we have a big problem of motility in the esophagus, in all esophageal atresia, but more important in the long gap. And this is impaired by some problems. The first one is ischemia. Ischemia, if you devascularized your esophagus, if you have a rough management of tissues, if you grab the esophagus in a grasper, we have ischemias which impair the esophageal motility. The redo, the re-redo, the re-re-redo after Fokker procedure impairs the motility of the esophagus. The tension, of course, any cause of inflammation. That's why I believe that we mustn't put a prosthesis inside the esophagus, internal prosthesis, because it worsens the esophageal motility. And of course, the use of lengthening technique, because of course, where we don't have any muscular wall in the esophagus, but just the scarring process around the mucosa, we have a total dysmotility. I will end with this. This has been advocated to today as the endobrachyesophagus, the Barrett's esophagus, where we have the gastric mucosa that replaces the normal esophageal mucosa. This is the gastric mucosa. This is the normal mucosa, esophageal mucosa. This child had a reflux, and he was complaining his reflux when he was 14. And when I did the endoscopy, I've seen that he had an endobrachyesophagus. And I performed, of course, a Nissen, even if I believe what Adrian has said, that we had an obstacle on a dysmotil esophagus, but we don't know what to do else. So this is what was done, the endoscopy 2 years after the Nissen. And the Nissen was efficient. He didn't complain at all. He had no reflux on the pH-metry and no reflux on the upper GI, but endoscopically, he had worsened his endobrachyesophagus. And that's the point where I want to come. You must remember that we don't know much about the Barrett's esophagus post-esophageal atresia. Is it related to the traction? Is it related to the reflux? We don't know. The only thing we know is that the risk of endobrachyesophagus, Barrett's esophagus, and then the adenocarcinoma is increased. Remember that in the normal population, the Barrett's esophagus is 0.2 to 1.5, and it appears by 50 years of age. After an esophageal atresia, and mostly after a long gap esophageal atresia, it raised to 1.4 to 8.5. And I heard Juan, who has said 13%. So really, the risk of Barrett's esophagus after a long gap esophageal atresia is something real that we have to consider. And it's not by 30 years of age, it's by 20 years of age, by the second decade. So what's the attitude? I believe that, and I'm not the only one, but an anti-gastroesophageal reflux procedure, whatever it is, Toupet, Nissen, whatsoever, do not relieve the risk. We just hope that it stabilizes the endobrachyesophagus. And that's why in all esophageal atresia, especially in patients with long gap esophageal atresia, we should have endoscopies performed by the second decade, even if we have done an anti-reflux procedure. I don't know how frequent we must do it. Maybe every 2 years, every 5 years, I don't know. And of course, it's mandatory if we have symptoms. And I mean that the adults have to be informed of that, because after 20 years of age, 18 years of age in some countries, we are not following this patient, but we are building patient with a future Barrett's esophagus. Now, remember that I retired in 2014. So unfortunately, I'm not doing this anymore. I'm convinced with what was said by Steve Rothenberg, by Dariusz Patkowski. the view that we have operating in esophageal atresia by thoracoscopy is far more better than the one we had when we did open. We can teach because we see what our residents are doing. That was not the case when we did it open. We have far less carrying process, so we can lengthen easily the esophagus than what we did the open way. So I think that this has to be done by thoracoscopy if possible. And what would I do today? I would change for what Darius has shown. I would do pen endoscopy at the very beginning of the procedure, see if there's a fistula or not, and I would do a thoracoscopy. If there's a fistula, I would divide the fistula with minimal handling by thoracoscopy. And then I would perform with an internal traction by thoracoscopy because we won't have those problems of infection, of cutting the threads and multiple adhesion related to many procedures. Should we perform a gastrostomy? I think yes, because I would like to feed the child through the gastrostomy and to take my time to feeding my mouth without the problem that we have to give the whole amount of food and to delay too quickly. So we can change very progressively between the mouth and the stomach. The alternative would be magnetic traction. I was very interested with what I've seen with that technique. I don't know how long the gap could be to use the magnetic traction, but I believe that it's something interesting. What for sure mustn't be done is this. This is a little girl, Eva. She was referred to me when she was 6 years of age. And at that time, she had 49 surgical procedures since birth for a long gap esophageal atresia with attempts to suture, attempt of a Fokker, 2 failed attempts of esophageal replacements. She had 49 surgical procedures at 6 years of age. That's a pity and shouldn't happen anymore. Thank you for your attention.
Thank you very much, Olivier, for your presentation, for your consideration, and this very interesting experience. Now we start with the discussion. Help me, my friend Girolamo and Darius. The first question is from Giovanna. Giovanna, you have a question for Adrian, please. Giovanna? Giovanna, you listen me? Okay. Probably now is not present. Girolamo, Darius?
Yes. Yes. What was the question? Sorry.
Yes, this question from the audience.
Can I, Mario?
Yes, please.
Darius, we were in Strasbourg a few years ago, and one message you gave me was very impressive, and I think is the problem. Be quiet. I think that this kind of surgery is really depend on the attitude of the surgeon. I have no experience with your procedure. I have very few cases compared with you, but we started with the trachea program thanks to Michele Torre. I think he is listening. And we started to face with very difficult cases. And I believe that thoracoscopy is better than open. Thoracoscopy can be done also after open failed TEF repair or something else. And I think that experience of the surgeon is the most important thing with outcome. About the long gap, I can't say I have no experience, but I could see from Pietro Bagolan the flap described by Bianchi and Gaff. And I think that the reduction of the upper pouch, elongating the upper pouch, and create a primary anastomosis is my attitude, not a big experience, but attitude. So thank you very much for your big experience, and internal traction, I think, is very nice.
Thank you, Matteoli, for your opinion. Thank you very much. It's really a great honor to hear it. What I would like to say, you know, of course, our experience with thoracoscopy for esophageal atresia is rather big if you think about the number of procedures we have performed in our department. And esophageal atresia is a special case for every pediatric surgeon. It's a challenge. Everyone would like to do such an operation because it's a brilliant operation. It's a beautiful operation if done perfectly. However, as Steven Rothenberg told me some time ago, we have just one shot for these babies. So we have to do a perfect operation at the first stage. And I remember 30 years ago, I got a scholarship in Bremen, in Germany, in West Germany. At that time, it was 88 year. And I had the chance to meet Professor Rebine. At that time, it was one of the most famous centers for esophageal atresia repair. And I couldn't imagine that 30 years later, we will operate such a cases in quite a different technique using video access. 30 years ago, the mortality rate in Poland was more than 90%. Right now, our rate of death is very, very small. And the new technique gives us quite new possibilities. And right now, I don't think that everybody should repair such a very rare case. I think that we should create 2 or 3, 4, 5 centers of excellence in each country just to do such a cases. It's not a big number. I don't think that every pediatric center should do these cases. Just think about it.
Okay, Darius, I agree with you entirely, but it is something that will not happen unless it is done by law, by politicians. We have had this experience in England with biliary atresia and similar situations. The only thing that achieves it is an order, a legal order, that you will not touch a case with whatever it is. You have to send it to the center. Otherwise, I'm afraid if we are left to ourselves, it doesn't happen.
Okay, so Bianchi, I discussed one from the English pediatric surgeon, why only a small number of cases are done by thoracoscopic approach. And he explained me that he has to teach young surgeons how to do it open. Of course, this is true. But if you discuss with adult surgeon, whether would you like to operate patient with cholecystitis, would you like to do a cholecystectomy by open approach? Would you like to do it just only because you would like to teach the surgeon to do it open? No, it shouldn't be done. So I think that, of course, probably it should be done by law, that such a very complicated patients with esophageal atresia, because it's not easy case. It's not just only esophageal anastomosis. That's a lot of other problems with these babies. They should be treated only in very, very specialized high-level pediatric surgery centers.
I agree with you entirely. What I am saying to you is that we tried this here in England with short bowel, and very short bowel, because of the question of lengthening and such like, which I am interested in. No one will give up their case, except to send them for transplant. Otherwise, they will do whatever they like. They will not agree to a center or 2 or 3 centers. And if you ask Mario here to take account from the listeners today, how many will give up doing esophagus to send it to the next colleague, I think you will find the same. No disrespect, my friend. I am speaking what I believe to be the truth from my experience in the UK.
You have a great experience. Thank you very much.
Giovanna, che sei ritornata, avevi una domanda per... you have a question for Adrian Bianchi, and after your consideration, please.
Informatica, ho una linea oggi non tanto stabile. Avevo delle domande. La prima, first of all, I would like to start with the last consideration made by Darius about the opportunity to have 4 or 5 centers in each country, for example in Italy, to be able to perform in a very proper way the correction of esophageal atresia. So this, it could be very difficult because first of all, esophageal atresia is a malformation difficult to be diagnosed prenatally. The best percentage of prenatal diagnosis is around 65%, so it's not so high. That means that in many cases you can't plan to transfer the mother for delivery. So you will certainly have patients who will born in different centers. My proposal is another proposal to have, as Italian society experts, as we have, in different procedure. And because I agree with Olivier Reinberg that it is not an emergency, so we have a little time to plan the treatment and also to study the patient in the best way. My suggestion is to have a team of competent surgeons who can support, can come to do with the local surgeon the procedure in a proper way. Then you are right, there are a lot of other things that we have to consider for the follow-up and for the study of this patient, and that can be also treated maybe differently. But in my opinion, in Italy, especially for the esophageal, we have to think, and also for biliary, maybe biliary atresia, we can transfer the patient easily. But for the esophageal atresia, there are patients that sometimes are not so easy to be transferred. So the best way is to have really task force who can help and offer the competence to treat the patient properly. Then I want to congratulate with you, Darius. You are really a fantastic mini-invasive surgeon and also a very good speaker, very able to teach in a very clear way. I would like to underline the importance that you have done in the last period not to perform gastrostomy. Because when I invited some experts to perform your procedure in my department, I had not the opportunity to invite you, maybe in the future after COVID pandemic. But my impression was not an impression, was a reality that gastrostomy is a noising procedure because give less elasticity to the lower stump, esophageal stump. So I think is a very good idea not to perform a gastrostomy, but to push a very, yearly treatment, stage treatment as you did. And I think also David has landed here the same opinion than you. It's better not to do the gastrostomy for this reason. Then I have some questions for Adrian, and I will finish. I have written in the chat before what is suggesting for an upper dilated pouch. Does he suggests to perform tapering. What kind of solution? And then, because long gap is also type 2 esophageal atresia. In type 2 esophageal atresia, the upper pouch is very small. So I think I didn't find the possibility to perform a flap. I am not a flap, I have not experienced a flap, but I have seen patients treated in other institutions. And I think it's feasible for type 3 or type A, but what to do in type 2, where the upper pouch is really very, very small. Then for Olivier, who is a fantastic speaker, always with able to explain everything in a very clear way, I have to see that I agree with the result of levaditis. I had the opportunity to follow for a long time patient affected, treated many years ago with levaditis, and they had a dilated esophagus, and at the end they lost the esophagus. So I think we have not to think of this kind of procedure in the present time. Thank you very much to all of you, and I will be very honored to hear from you your answers.
Adrian, after there is a question from Ernesto Leva, and after a comment of Olivier Reinberg. Please, Adrian, you want?
I only heard part of your question to me, Giovanna, because the internet went down. But also I saw that you sent a question. You asked what I would do if the upper pouch was not very wide. It is always wider than normal, and it usually is wide enough to allow sufficient tissue to turn a flap down to give me a wide anastomosis. Now, if I cannot do that, and I cannot bring the esophagus together with a wide anastomosis without tension and without pulling up the lower pouch, then for me, this becomes similar to a long gap, and I will do an esophagostomy and then do a jejunum somewhere around about 3 months or so. So I don't know if that was the question, but because I lost you.
Yes, it was the question. I lost my connection too. It was the question. Thank you very much, Ade.
Okay.
Ernesto.
Yes, thank you. Darius said that esophageal atresia is a very difficult disease, and I fully agree. And I still remember what Heinz Rode in Cape Town told me every time I approach an esophageal atresia. Remember that esophageal atresia is the macumba of chirurgia pediatrica, and I still believe it's true. So my question is, in long gap, that is a very difficult type of esophageal atresia to treat. I want to ask to Olivier and to everyone, when you have a long gap in type C, that means you have to ligate a fistula, but the gap is too long. What do you do with the distal pouch? You fix somewhere, you leave it free in the mediastinum, you put in tension with some structure around. So which is the best strategies? Because you said it's better to leave and wait, but leave where? Leave in the mediastinum or fix somewhere. And I agree with Giovanna concerning the centralize the cases. I still believe it's not possible for any of pediatric surgeons because the ego of pediatric surgeon is too strong, but probably to create a group of person of experts that can move in different centers and help the doctors to treat difficult cases, I think is a very good idea.
Olivier, and after Juan Tovar. Olivier, your comment, please.
Thank you. First, I want to say that I agree totally with what Giovanna has said. We mustn't move the patient. They're too weak. We must move the surgeons. And to have a team able to travel and help, most of us who have been teaching minimal invasive surgery are used to travel. And this can be done for many, many purposes. So it's not an emergency in esophageal atresia. And we could have teams of some people trained for that, traveling and being able to operate even by thoracoscopy in many, many places. To perform an esophageal atresia by thoracoscopy doesn't need so much material. And most of you have already a set of minimal invasive surgery, and to travel with some tools, as I've been doing for years, it's very easy. So yes, Giovanna, that's what we must do. But before this, and I would say that I have the same worry as Juan and Darius, is that we have so few cases of esophageal atresia that we have to think about something. And the answer is very easy. It's just to have, we have the tools for practice on models, on shame surgery, on virtual models of esophageal atresia. And many have been developed which are coming close and close to the reality. And an answer would be that before performing an esophageal atresia, you must give the proof that you have been trained in a center like the one with Mario, like with Darius Petkovsky, and you have been performing 5, 10, 20 virtual or model cases before doing a real one. And this won't be against the ego of the surgeon, and it's achievable for in most countries. And now to answer the question of Ernesto, of course, when I said you don't do anything in a real pure atresia with blind pouch up and down, for a type with the upper fistula, we have to ligate the fistula, but we don't touch the pouch. I mean, the fistula itself is rather short. We can't use the fistula to do something with the long gap esophageal atresia. So we have just enough place to close it. Of course, we don't have, all of us don't have the staple that Steve Rothenberg has been developing, which is a very good tool for that. But we're able to cut the fistula and put some stitches on either end, and then that's it. You don't do anything else to avoid any attachment. I don't try to bring I would say I didn't bring the upper pouch down. If I was doing this surgery today, I would do what I've said. I would do like Darius, because I think that it's an atraumatic way to minimize the distance in between the two pouches with the minimal handling.
Thank you very much, Olivier.
Did I answer your question, Ernesto?
Yes, yes, it's fine.
Thank you very much, Olivier. Juan.
Yeah, I have only a comment that is to bring you back to earth a little bit. We have been very impressed and even mesmerized by the beautiful techniques and approaches that are shown by very skillful surgeons, and I am always very impressed by that. But I recall you that we decided today to take a large scope on the problem of the lung gaps, and I'm going to bring you back to earth. I think we have about 100 participants now, most of them certainly from Italy. A rough estimate shows me that in Italy you may have 150 cases of esophageal atresia a year. So that means that you may have 15 to 25 cases of lung gap, including types A and type B. And that means that most of you are not going to be confronted with one single case of lung gap every year. And only a few of you will see one or more than one every year. So I think it's very important to be trained in the techniques. It is very important to be up to date in the different things that we introduce into the techniques of treatment. But most of all, I think you should take into account that all crocodiles with large experience have said today, is that you must tailor your attitudes on this particular problem, thinking that the future of the children you are treating is the most important thing. And you need, as I think Adrian and also Olivier explained very well, you need a happy child eating by mouth and with good function of the esophagus. If that takes, I don't know what, I mean, the attitude you select is the best one. Select the one, but thinking always that this is a long-term problem. And I don't believe the magicians that are very good at the operation, but forget what happens in the next 15 years. So keep looking at what happens with your patients when you have the patients, and look at the patients or the others that have seen the patients, and learn how to treat this particular problem. Thanks.
Mario, se posso?
Yes, yes, please.
I want to reinforce again what Joan has just said and what I said earlier at the beginning of my talk. I think you have to stop thinking of what to do with the esophagus. You need to consider what is the need of the child and his family and the long-term prospects for quality of life. What you do with the esophagus is secondary to that. And that is why I am suggesting to you that you start to think not of the esophagus, but of the child, the physiology of the child, how the child grows, how the child learns. Swallowing and eating and breathing are extremely important aspects. So your management should depend on what is the impact of what you do, delay and repeated interventions and not feeding the child for long periods of time. What is the impact of these necessities in your technique on the child? And if it is not in line with the physiology of the child, you should think of how best to change it. Now, whether or not you will ever achieve a group of surgeons who have to be voted or chosen by someone, who have to be respected by their colleagues, who will ask them to come over to do the case with them or for them, well, I wish you luck. I was never very much able to do that myself. But I think the only way is for people to work to present their results, and then they get picked automatically because people believe in what they are saying. Grazie.
Thank you very much, Adrian. Girolamo.
Other 2 points to discuss. First one is we are facing with the esophagus, but we have also to deal with the trachea. The problem remnant of the foregut, the so-called diverticula of the trachea, is a big problem. And this is one subject of discussion. Where do you close the fistula and how? I don't believe the stapler is a good technique. Someone in other congresses, in other societies, said open the trachea to close the fistula. This is one. The other subject is always about respiratory tree is about tracheomalacia. When treat tracheomalacia, how to treat tracheomalacia, and who. This is another problem. My question is to Juan Tovar. You are a very expert, and we discussed many years ago about motility disorder and manometry of the esophagus that always is not normal. Now my question is it a congenital motility disorder, or is it a traumatic motility disorder due to vagal injury, burns, and so on? What is your impression now?
Thank you very much, Girolamo. I think both components exist, and I'm sure that you are aware that there are anatomical dissections by Professor Davis from South Africa in untouched specimens of esophageal atresia that show very well that the extrinsic innervation is abnormal in esophageal atresia, both for the vagal and the laryngeal component of innervation. This can be reproduced in experimental animals, as my old colleague, Dr. Chi, proved in Melbourne after leaving Madrid. And we have shown that in human specimens of esophageal atresia as well. So we have abnormal innervation, extrinsic and intrinsic, but also, as you say, mobilization is a trauma for the esophagus, both the upper and the lower one, and the larger the mobilization, the more severe the lesion. So I think both components exist, and both components contribute to a bad function of the esophagus in this particular condition. Yeah.
Darius?
Yes. You know, if you think about motility of both esophageal segments, I think that very important is the technique that you are using. This is why we stopped to use electrocautery. We are just only using blunt dissection. And right now we have more than 40 cases of esophageal atresia that were repaired without any electric knife, without any suction, without any irrigation. This is completely bloodless operation, and only gentle handling of the tissue, staying with the tissue borders, dissection only as far as is needed, not too much, guarantee that the function of the esophagus will be quite good. You know, we have a lot of cases, and I hear about a different complication, a lot of problems. Of course, we have also complications, we have also problems, but not in such a big number of patients, you know. Majority of patients have some stenosis, but it's easy to treat with 1 or 2 dilatation. I have only less than 2 or 3% of patients that required any fundoplication. And just only very, very complicated cases required redo or esophageal substitution, but no other. So probably the technique and the experience is really, really very important.
Thank you very much, Darius. There is any question from the audience? Giovanna, you want, but there is a problem with your line. Okay. I think this is a very interesting afternoon. It's very interesting meeting. Thank you very much to the good friend Juan, Olivier, Adrian, Darius, Girolamo, and also Steve. We see the next meeting is the 17th of February, and we discuss about clinical case. Darius, if you want, you are welcome in this club.
Thank you very much.
And if you are interested, we discuss one time clinical case and one time is a panel of one argument like esophageal atresia or other arguments. If you want, you are welcome.
Yes,
Because we are all friends.
Thank you very much. It's a great honor to me.
Okay. Okay. I see you in February. Thank you very much. Thank you very much indeed. Grazie Girolamo. Thank you.
Professore, la slide.
One moment. This is the slide for, excuse me, for the credit. Okay, please. This is the slide. And Friday, this meeting is on our website. There is the registration of the whole meeting and this slide. Okay? Thank you very much and arrivederci.
Arrivederci.
Arrivederci. Arrivederci.
Grazie.
Ciao a tutti.
Ciao Adrian, grazie molte. Grazie.
Non c'è niente.
Ciao, 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 ciao.
Buona serata a tutti.
Ciao Francesco, ciao. Ciao Dennis.
Ciao Mario e complimenti, eh?
Mi raccomando il caso, io ho già registrato per il 17.
Sì, te lo mando prima così mi inserisci.
Ecco, mandami le domande. Perfetto.
Vabbè, un abbraccio.
Ciao, grazie a te. Ciao, ciao.
Arrivederci, grazie prof, grazie a tutti.
Ciao Marco, ciao, arrivederci.